This episode of HIPcast is brought to you by FairCode. Are you looking to maximize your hospital's revenue and streamline patient documentation? Introducing FairCode, your trusted partner in DRG reimbursement optimization. FairCode's 100% board-certified physicians collaborate seamlessly with your coding, CDI, and medical teams to conduct lightning-fast chart reviews, pre-bill, and post-discharge to ensure accurate reimbursement. Only 10 to 15% of the charts FairCode reviews requires changes, yet their recommendations result in a significant boost to a health system's cash flow. Are you worried about risk? Try FairCode's 13-week trial. If they can't pay for their services, they'll keep reviewing charts until they do. And by the way, historically, FairCode's 13-week trial leads to an ongoing partnership with a remarkable 3-to-1 hard dollar ROI. Don't miss out on the opportunity to enhance your reimbursements. For more information about FairCode and how you can experience the maximum in healthcare revenue optimization, contact Steve Hansen at shansen@faircode.com or by phone 61.
Welcome to the show today. We are so excited. I'm going to read a bio and introduce our guest speaker today. But before I do, I want to level set something for all of you. Seth and I have known our guest for quite a long time today, and our guest, Lorie, served in the House of Delegates for Mississippi at the same time Seth and I were serving in the House of Delegates for Tennessee. And if you've never served on the AHIMA House of Delegates or on the board, and you haven't seen how those meetings kind of unfold, you're sectioned by, there's an identifier. So this is Tennessee's delegation, this is Mississippi, this is Hawaii, go through it like that. And so we affectionately call our guest Mississippi. So if throughout the show today, you hear us say, Mississippi, tell us about something, we're actually talking to Lorie, and she will respond by answering, because that's how we talk to her. But it's my very great honor to introduce you to Lorie Mills. She's an RHIT and a CCS. She's the owner and senior consultant at LBM Consulting in Hattiesburg, Mississippi. Lorie has served 3 times as president of the Mississippi Health Information Management Association. So she's earned the name Mississippi, and she's been an active member of the Mississippi HIMA Board of Directors for 13 years. Mills has served on the Advocacy and Policy Committee for AHIMA for 3 years and has been a member of the House of Delegates for AHIMA for 9 years. Twice as long as I have, I think. Over her career, Lorie has had the opportunity to be a speaker for the Mississippi Hospital Association, Mississippi HIM Association, Tennessee Health Information Association, and Mississippi Healthcare Finance Association. Mills has co-authored an article that was published in the Journal of AHIMA called Red Flags for Myocardial Infarctions, Coding and CDI. She's also worked on a project with the American College of Cardiology and developed an ICD-10 code for non-traumatic myocardial injury. And that was released in October of 2021 in the coding updates. Lorie began her career in 1994 and has specialized in coding and documentation integrity with an emphasis on provider education. She has 3 children and she lives in Hattiesburg, Mississippi. Welcome to the show, Lorie.
Thank you guys for having me. I'm so excited that you asked me to be here.
Absolutely. It's our pleasure. We're thrilled to have you on here today. And we're going to talk today about payer denial, something that forward, backward, multiple payers, all kinds of rules, things like that. So today we'll talk a little bit about, or a lot, depending on how chatty we get. We like to talk, the 3 of us. So we may talk a lot about the different types of denials that we face in the health information revenue cycle. And then also kind of some of the tech around some opportunities to help, I guess, maybe mitigate some of the risk of payer denials. And then we'll talk about some different practical things that you can help as a health information management professional.
Well,
Seth,
Shannan, I'm a bit of a fish out of water in this conversation. Now, Mississippi and I are not fish out of water in the sense of us together. We have all kinds of fun times in any city that we've gone to.
Yeah.
But when it comes to denials and denials management, I have zero clue what's occurring. So this is going to be very educational for me. And Lorie, I would ask and start, what is a denial and what are the types of denials? Help me understand that from a basic level.
So the denials arena in healthcare has grown tremendously over the last 10 years. It's just exploded. I was reading an article yesterday that talked about that the amount of denials has increased by, I think it said 15 or 20% since 2016.
Wow.
It was something like $3 billion that's being denied on the front end. And 60% of that's not even appealed. It's a thing of bandwidth. You just don't have the bandwidth. Providers don't have the bandwidth to fight for those denials and fight for that money a lot of times, because an average denial costs about $25 per claim to fight. And that's a minimal. Then you have your complex denials. They may cost upwards of $120 to fix. It just depends on what it takes to correct it. But you ask about the kinds of denials we're seeing. So there's 3 buckets you can put a denial in. So you have your administrative denials, you have your coding denials, and you have your clinical denials. And so your administrative denials are going to be things that happen in like patient registration, you're missing authorization, or you miss timely filing. Maybe everything was done on the back, the front end correctly, but it gets to the business office and gets hung up and you miss timely filing. A lot of payers have a 90-day timely filing limit that if you don't file the claim within 90 days, they won't pay it.
Really?
So that's a huge one. And it's because a lot of times just think we're having to wait on physicians sometimes to do things for us.
What?
A health information professional having to wait on a physician to complete documentation? This is new news.
So it can put you up to the deadline on those that have 90-day turnarounds. Eligibility denials. Patients come in, they don't have their insurance card, or they give you the wrong insurance card. Well, by the time you file that to the payer, it comes back as a denial telling you they're not eligible. And then you've got to try to figure out, okay, so I contact the patient, I get the insurance information and file it to the right payer. Have I missed my 90 days at that point? It's just technical things like that. Coding denials. We see a lot of coding denials with modifier usage, incorrect modifiers. We all know that they're creating modifiers every year. There's new modifiers that come out. All the drug modifiers now that are out, it's just so confusing to try to keep up with that. So that's a large issue. Invalid HIPcast and CPT codes. People that don't update their charge masters appropriately.
Data governance, baby.
Yes, that is not my area that I just love. I just don't like doing the charge master, but I can do it. I just don't like it. The other thing is inpatient procedures performed in an outpatient setting. And we have Seth, you may not know, we have what we call inpatient only list, which means that those procedures can only be performed in an inpatient setting. Well, you have providers, these patients may not have to stay overnight, and they may not even stay but 12 hours. Well, they're not putting them in outpatient and in inpatient. They're leaving them as outpatients because they don't stay. Well, we get a denial because that procedure can't be done in an outpatient setting. And Medicare, CMS is trying to do away with inpatient only list. They tried it a year or so ago and found out it didn't work. We had to put it back in. So we're still running off that. The third type of denial are clinical denials. And these are going to be your medical necessity denials, your inpatient DRG downgrades. They throw out a diagnosis and say it wasn't clinically valid. And another huge area for clinical denials are inpatient downgrades to observations. Lots and lots of payers are coming back and saying, no, this doesn't meet inpatient criteria. We're going to make it an observation. And the reason for that is an inpatient DRG may pay it $7,000-$8,000, whereas an observation may pay a third of that, depending on what the patient has done. And so it's a very time consuming. It takes a lot of resources to manage all of those.
That's interesting. So I've got a follow-up question about timely filing. And then also maybe one about, I'm writing notes as you're talking because I'm thinking about the health insurance and how they change, they change your inpatient stay by the guidelines, Milliman or Interqual or whatever it is, to outpatient. But what if you've done an inpatient only procedure? But let me get to the first question. With timely filing, if a claim hits timely filing and you're not able to, you get denied for timely filing and it's accurate, it's not day 91 and you filed a claim and they're going to deny it, are you allowed to bill the patient after that?
No, it's hospital's responsibility.
Even if the patient didn't give you the correct insurance information, is that still true?
Mm-hmm.
Wow.
Because it's the hospital's responsibility to get the claim in on time. So yes.
Wow. So the second question then is about the health plan. So you talked about the inpatient only. I didn't know we were going to go in the direction of inpatient only list. I'm glad we did though. This inpatient only code list, if a health plan, if a hospital has admitted a patient, they've had a short stay, but they had a procedure that was inpatient only, but they're under that less than 2 midnights or whatever, they could still fall in that observation space. And then if a health plan looks at their guidelines and say, oh, we're only going to pay this in observation status, has that ever happened to you where it conflicts with an inpatient only list? I don't even know if that really happens. To me, it just seems like it could.
So a lot of times what happens is your commercial payers, and you guys know, they do whatever they want to do. So a lot of times they will change it to an outpatient and they will pay it based on an outpatient, but CMS guidance will not allow Medicare to pay those as an outpatient. So they have to be inpatient. But yeah, a commercial can come in and tell you had a patient in there for 10 days and they can come in and say, no, we're only going to approve observation. And that's what you have to bill it as an observation. And that's all you're paid as. Yeah.
And Medicare Advantage follows kind of a commercial rule there, right? That's not traditional Medicare. So they're really under those commercial type rules.
There has been some legislation. The OIG looked at a lot of the MA plans and found out they're not following CMS guidelines for approving services and things like that. And so they're saying that your MA beneficiaries are not getting the same care that regular traditional Medicare patients are getting. So they're looking at that to make those MA plans follow those guidelines. And it's going to be a fight. There's a lot of the MA plans, they don't want to follow the Medicare guidelines.
Wow.
Unless it suits them. That's what we found. I'll tell you.
Hey, we'll have payers listening, so be kind.
I'm being kind. I'm being kind. I did have a case, and I can say this, had a case a few years ago that patient came in, they had a heart attack. We didn't have any information on them because, they weren't conscious. They were with no family. They coded in the cath lab. We sent them to ICU. Patient expired in ICU. They were in the hospital for 14 hours. The payer come back and said because they were not in the hospital the 2 midnights that they were only going to pay it as an outpatient.
Wow.
Oh my goodness.
So, yeah. So we checked. Okay. So we sent it in then on a bill type 131 for an outpatient. And you know what? They denied it for prior authorization.
No, my
Did you not?
Goodness.
And we wound up writing it off because by that point it had gotten too old, and we were all trying to figure out what to do with it. So things like that happen, and we're talking a $100,000 case.
It has to be eye-opening to folks like me that don't live in the revenue world. Every day, the coding world is, and even listeners that aren't in traditional the health information profession, and like. The reimbursement for any kind of care is incredibly complicated on the back end because there are so many rules from the federal regulations to the provider contracts that you have. And then there's the games that are played between the two. It is fascinatingly difficult.
Yeah, I'm glad you didn't stop with fascinating.
It's difficult, yeah.
I'm so glad you didn't stop with fascinating because I would have been appalled by that. It is so challenging. And And you really do have to have qualified coding staff trained and billing
Yes.
staff. Like it
Yes.
is a combination, right, of those things. But one of my favorite things that we talk about on the show, almost every conversation we have, we're interested in kind of today's struggles as a health information professional in the role that you have or the things that you know about. But we're also interested in the technology that's available today, or the technology that's kind of a promise for the future to make things more efficient, or to make better outcomes, or whatever the end game is supposed to be. So talk about some of the tech that is maybe available today to help mitigate denials, and then also anything you might see coming down the pike.
Okay. Yeah. So one thing that really we try to do in our EMR, was try to build things that would catch these denial potential denials. We would build. We had Epic at that time. I was at the hospital. We had something called Revenue Guardian that could evaluate different coding rules, and if it was an ER chart that was missing a facility level, it would put it in a work queue for somebody to review. Those kind of things, and charge evaluation. Did you have all these injections, but you don't have any medications charged? Or do you have all these medications with no injections charged? So it would catch things like that. But the problem with it being in your EMR is you've got to have people to support that. And you guys know how often coding changes. I mean, we get updates every
Constantly.
quarter, and twice a year for diagnosis, and every quarter for our CPT. And the big thing is, during COVID, we were getting updates every
daily.
week. Oh,
yeah.
I just about didn't survive COVID. I'm just going to tell you, just from the
administrative coding data, right?
Yeah, I even called CMS one day and asked them a question, and they said, "Oh, we really don't know how to answer that." And I thought, "Well, you wrote the rule. What do you mean you don't know how to answer it?" So you run into that a lot too. I can't answer your question. Well, you wrote it. Tell me what to do with it.
Yeah.
But yeah, so those kind of things built in your EMR, but it does take a considerable amount of staff to stay on top of those guidelines and those regulations and change the things that need to be changed in the EMR. Because most of the time when you change something in the EMR, a lot of times it takes, month to 6 months or a year to get changed. Well, by then they've already come up with something else. So, I mean, you're behind the line. Outside vendor tech is an area where they do a lot of these things that are in our EMRs, but they manage the rules and the guidelines. So you just basically have an interface in with your system, and it evaluates claims for you. A good billing system. If you don't want to go out and get one of these it's really expensive systems to evaluate, make sure you have a good billing system to evaluate your claims before they go out the door. That's very helpful. Because you can catch mistakes before they get out to the payer, because once it gets to the payer and comes back, it usually it's a lot more difficult to figure out what's wrong with it, who gets it, where does it go. Whereas if you can fix it before it goes out the door, it's much better.
Yeah, a lot more expensive. I wonder the cost of using one of those softwares that you're talking about, some of that technology to clean it kind of before it goes out. I wonder how much more cost effective that is than trying to reprocess those denials and clean it up.
Yeah. It just depends. And it depends on the size of your facility. If you have a small facility, you're not going to want to go out and get one of these big boys that cost millions of dollars to put in, and you're paying for $100,000 a year. But if you're a big facility, or a big health system, it may be pertinent to purchase something like that and put it in and work with them. I found that because I work for a lot of small hospitals when I'm consulting, and I found that a good billing system a lot of times will have that information written into it, the rules written in, and it'll catch things before it goes out. So
that's good. I wonder, I'm going to throw a question at you that we haven't talked about. I know in prep, we talk about some questions, but so I've worked for a payer, and I know that one of the things that a payer employs to kind of help is they have an overlay. Some of them are kind of like a pre-claims processing edit system, and then some are like a post-pay audit system where it's all just processing just through the data, right? Kind of what you're talking about. I wonder, do you find conflict with your billing system scrubber and whatever software that the payers are using fairly consistently?
Yeah, sometimes it is just because, there's so many different payers and you may not have the exact rules built into your code, your
Mm.
claim scrubbing system that's payer
Oh,
specific. And so
yeah.
trying to keep up with payer specific is very difficult. I mean, it's one thing you've got your federal guidelines and your
Mm-hmm.
state guidelines for your Medicaids and your Medicare that you're trying to update, but then you've got all these commercial payers that have different requirements or have different things they want things, and it makes it very difficult even for a coder if you don't have all of this technology trying to remember, okay, I have to code Blue Cross this way, I have to do
Mm-hmm.
Medicare this way, this payer doesn't like this CPT code and we have to change it on the back end
Mm-hmm.
to something else. It's difficult to manage.
Yeah, I've even seen some contracts written that had specific codes in them,
Mm-hmm.
like a CPT
Yep.
or a HIPcast code, and then those codes change, and then you're
Yep.
stuck because your billing system, I mean, you don't write it, not everybody writes contract in evergreen language that says this code or its
Right.
successor. So
Right.
you're
Yeah.
stuck. Your system has to then, even though it's not a valid code anymore, you've got to do code logic, not our code logic, but like computer code logic to make that still be available for
Yep.
billing for that particular provider. But
Yep.
Lorie, I think you're right about the payer specific policies, medical policies and coding rules for
Mm-hmm.
each payer. We could probably have an entire show on
Oh
that,
yeah.
but I don't know if anybody could handle listening to that for a whole show. That's a lot.
It's a
That's
lot.
pretty
It's a lot.
painful.
It is.
Yeah.
It is. And that's when, we talk about the roles that HIM professionals have in the industry and how our roles change and we have to adapt. Payer contracting is a role that revenue cycle can do. And, we need people that can go in and help write these
Yeah.
payer contracts to where that providers are being treated fairly. And,
Yes.
we are getting to take care of our patients, but we're also getting paid to do that work.
Man, that's such a great point. Providers getting
Mhm.
paid fairly, but also from a contract coding standpoint,
Mhm.
so there's no conflict. That's really good.
Right.
So, along those lines, what are some really practical steps that a provider or a hospital could implement to alleviate denials?
So the first thing that I like to do when I go in, because I do denials, and that's a lot of what I look at when I go into a facility is, okay, what are your top denials? Whether it's your top 5 or top 10, what are your top denials that you're having? And then do some data analytics on that and find out, why am I having those denials? Do I have a coder that is consistently coding something incorrectly? Do I have something built in my charge master incorrectly that's causing us to get these denials? Is it a matter of the workflow for prior authorizations isn't working?
Mm.
Do we have a breakdown between our physician offices and our registration department that's causing us not to get our prior authorizations and we're getting denied? All kind of different things that I can think of. I like to break them down even to department specific, like radiology is an area that we see a lot of denials. Well, why are we getting them in radiology?
Mm.
Is it because we're not meeting medical necessity and we don't have anything from the physician office? Well, if you're not meeting medical necessity, why are you scheduling these very expensive MRIs and stress tests if you know they're not going to be paid for? You can't schedule until you get a medical necessity diagnosis. You've got to have it. So those are the kind of things. And doing education into the departments when you find out where your denials are at. If it's patient accounts, registration, coding, whatever, a clinical department, doing department specific education is one area that is there's a need for it, because a lot of times we all know clinical and finance do not speak the same language. So not at all.
Really?
So you've got to find somebody that can go in there and talk the language to these clinical people so they understand and realize it's not about money all the time. Now, to revenue people, it is a lot about money. But for clinical people to care, you have to make them understand it's about patient care and patient safety. So, if I'm getting denied for all my MRIs and I need a new MRI machine, is my facility really going to say, hey, well, it's not worth us paying $3 million for a new MRI machine? We're not going to do that. So, you got to make it about patient safety. It's like talking to a physician. I don't talk to a physician about money unless it's his money.
Yeah,
because
that's smart because he doesn't
he
care.
doesn't care if it's not his money. So I usually, from a patient safety standpoint, how your documentation makes it better for the patient, what it does for the patient. So
it sounds like a lot of education is needed for many of the departments that are involved in healthcare, whether it's the finance side or the clinical side. Of how do you have skilled labor, and why is it important to have skilled coding and billing staff that ultimately we want to be credentialed, right, and to understand this full process? I can see the importance, but how does that importance lay out in your eyes?
Well, and a lot of times facilities don't put a lot of that into, especially the billing departments. They think, I can get somebody off the street, come in, I can give them a quick training course and they can bill these claims. Coding's not quite that bad, but it is. And people think, a coder's a coder, and that's not true. They're not. The importance is, for one, it's definitely going to hinder your revenue if you do not have these educated people in these areas doing these positions. The other thing is you're really going to you're losing money. I mean, I did a coding audit for a facility. I looked at 20 accounts. 7 of those accounts had issues, and I had DRG changes that could potentially be worth up to $35,000 on 7 accounts. Because the physicians needed to be queried. There were not queries done. The coders don't know the clinicals for clinical validation. They don't know how to query if the doctor doesn't document it. So, $35,000 for a little bitty hospital, 25, 30 bed hospital, that's a lot of money.
That's helping you make payroll.
Right. So it's very, very important. And not only that, you want someone in those areas that, they have some initiative. If I see that somebody is doing the same mistake over and over again, I need to make sure we get that mistake fixed and not just sit back and keep letting it happen. So if I have coders have come to me before and said, I'm having a problem with Dr. So-and-so. This is something he's consistently doing. Well, I go find Dr. So-and-so and I may take him a piece of candy or something as an incentive.
Got a problem.
No, Seth, no. You can't use the word bribe.
No, come on. No, you're going to get us in prison. Come on.
It's a federal prison.
I have baked a beanie cake for incentive. But anyway, go find that physician and talk to them, because a lot of times it's not that they don't care. You have a few that they don't care and that, they just want to be difficult. But for the most part, they will take what you say and they will try to do better. And then they'll know, hey, I got this person that if I have a question, I can call them and ask them and they'll help me. I've had physicians call me several times and ask my help. Hey, how do I document this so it's appropriate? And that's important to build that relationship between your medical staff and your coders and CDI.
Maybe that's what we need to encourage. Instead of the health information management department sending physician queries, we need the physicians to send the health information management department a query. We can sit back and say, you guys ask us the questions. We're the experts.
I tell them all the time that, because we had a very high query answer rate at my last facility. And everybody was like, well, how do y'all do that? And I said, I don't know if they really like us and they want to help us and answer the queries, or if they just so sick of us, they answer them so we'll stay away from them.
Get away.
I hadn't figured out which one of the two that is.
What was your candy budget?
Yeah. That's true.
Yeah, that's the key. In your viewpoint in doing denials, and what are the most common denials or the top denials that you see?
Prior authorization is one. That's a huge one on the front end. Then we have our coding denials. A lot of times, like I said a while ago, modifiers, incorrect modifiers being on the account. And then clinical validation for DRGs are huge. That is, and there's some language out there that says a coder is not qualified to do a clinical validation review. I don't believe that because I do them and I'm a coder. I'm not a nurse, but it does take someone that's been in the business a long time and that has a good understanding of what the clinicals are for these patients. No, I've not treated patients at bedside, but I got my little, I won't call the name, but I have my little CDI book that I look at all the time. And I go through and I find what I need to know and learn that. But it is important that the DRG validation is a huge one because they're throwing out all these high-risk DRGs or high-risk diagnoses such as sepsis, respiratory failure, encephalopathy, all of that. And if it's not documented appropriately, they're going to deny it. So it's important to make sure your medical staff knows how to document for those types of illnesses.
Lorie, that's a really good plug for AHIMA as a profession. So one of the major, what I think sets us apart in terms of understanding that clinical disease process, if you have an RHIT or an RHIA, or if you graduated from an accredited program with health information management, health HIT, I think is probably what it's still called. But if you graduated from that, you've had pharmacology, pathophysiology, A&P1, A&P2. Yep. Not only are you having coding courses, right? You're actually having clinical type education. We are not hands-on. Our practicums are health information operations. Right. It's not going to the bedside and doing a venipuncture or taking a temperature or those things. But the point is so valid. A coder is not a coder is not a coder. It is not, really AHIMA's training for many years, many years has set us apart with the understanding of that disease process.
Right.
Signs and symptoms and all of those things. And so as we wrap up, I just have one final thought that maybe you could weigh in on. So I was listening to you talk about the payer specific policies and the constant changes in coding, the changing coding guidelines. So the, what's it called? The Coding Clinic. I think that's a quarterly publication, but they publish corrections in between sometimes and things change. So if I think about tech that I'm trying to encourage the health information profession to understand the value of AI instead of fearing it, right? That's one of the things that Seth and I want to talk about is the tech-enabled health information professional is a very highly qualified person to do a lot of things. So if you think about AI can never replace that human because unless somebody is entering that data every day into that AI engine, that is payer changes, policy changes, local LCDs, NCDs, all of those policies that are impacting and weighing in, you're not going to be able to not have coders that are at least validating. I'd love to see us move to autonomous coding kind of place where our coders become like an auditor. So that's a highly skilled workforce that can then inform, hey, this keeps getting this wrong. Somebody in the AI code place needs to put this in, whatever. So what are your thoughts on AI and that AI helping mitigate some of these denials?
We had this conversation actually a couple of weeks ago at a meeting I was at AHIMA. We've got to start looking at how are our roles going to change. AI is never going to make coding go away.
Sure.
We will always be here, but our roles are going to change. How we interact with that machine learning and technology is going to be different. And like you said, more of an auditor standpoint, I believe is what we're going to do. I would love to have some kind of coding for like labs and things like that a person never had to touch it, but it worked appropriately. There are some out there that they do that, but they don't necessarily always work appropriately. So you still got to have people reviewing and know, this is not right. I get tickled. I've seen people take all the diagnosis that a physician puts in, and I'll look, and there's, hypertension and congestive heart failure coded separately, and kidney disease, and I'm going, all of that's combo coded. You got to know that, So that's kind of how I'm like you, an auditor standpoint. That it can be done on the front end, but then on the back end, it's going to have a knowledgeable, skilled coder to look at that and determine is it actually correct.
That's awesome. Well, Lorie, thank you so much. It has been incredible. I've learned more about denials than I've had to listen to or learn about in I don't know, since like
Since school for me.
2011. Well,
Yeah.
since I left the provider side,
Yeah.
even in my last provider that I worked in, I was in IT for, so I wasn't doing the denial stuff. So I had forgotten a lot of those things. When you started talking about policies, I was thinking about those local coverage determinations and things, and I hadn't thought about them in years. So thank you so much for sharing your knowledge with us and for agreeing to come on this show. And Mississippi, it's been great to see you.
Hey, I'm so glad you guys invited me, and I've enjoyed talking with you guys about denials. It's such a big part of what all we do, and I'm glad to be here.
That's right. Well, I also want to thank our sponsor for today's episode, which is FairCode. And they say if you're looking to maximize your hospital's revenue and streamline patient documentation, FairCode is the trusted partner in DRG reimbursement optimization. FairCode's 100% board-certified physicians collaborate seamlessly with your coding, CDI, and medical teams to conduct lightning-fast chart reviews, pre-bill, and post-discharge to ensure accurate reimbursement. Only 10 to 15% of the chart's FairCode reviews requires changes, yet their recommendations result in a significant boost to a health system's cash flow. Are you worried about risk? Try FairCode's 13-week trial. If they can't pay for their services, they'll keep reviewing charts until they do. And by the way, historically, FairCode's 13-week trial leads to an ongoing partnership with a remarkable 3-to-1 hard dollar ROI. Don't miss out on the opportunity to enhance your reimbursements. For more information about FairCode and how you can experience the maximum in healthcare revenue optimization, contact Steve Hansen at shansen@faircode.com or by phone 615-600-2166. Shannon, until next time, my friend.
See you next time.